and a courtesy to Dr. Balaji sir and other cardiology team. So if you see, this was the mass which was there in the right atrium and right ventricle contributed to this. So he underwent transesophageal echo, which also demonstrated the mass. So now it's basically a mass which is there in the heart causing these symptoms for this patient. Now again, we don't know whether it is primary or secondary. We don't know what was the mass, whether it is same lymphoma which was there, or it could be something else, some other primary cardiac malignancy like myxoma. So again, the CT was performed. It was showing a large infiltrative mass from the pericardium extended all over to AV groove, right atrium, right ventricle. It's a Cori primary cardiac tumor or a lymphoma. That was the initial DDs. Again, the PET was performed. If you see, there was a uptake only in the cardiac, like only in the cardiac region. There was no uptake anywhere. Again, we discussed with our nuclear medicine department, Dr. Nageshwaran sir, because what could be the reason. Again, so we need to get the biopsy done, because without that it is not able to be proved. Like, so now we got opinion from our CTVS opinion team obtained. They said that it is accessible. Like basically the biopsy accessibility is there, but still the chance of bleeding and risk to life, that's a very high risk to life, because we don't know what we are like. We had to open and do all the surgeries. Again, interventional radiology opinion was obtained, and he also said the accessibility biopsy is there, but it can have very high risk of bleeding, could be possibility. Again, I discussed the same with the cardiology department, and he said, okay, no problem, sir, leave it aside. We will take from a transfemoral approach. So the approach photos I don't have, but he did the routine like a transfemoral approach, and he has taken a biopsy. There was a good chunk of a biopsy. So now we have a biopsy. Again, I got a call from Seju sir saying that it was a non-Hodgkin's lymphoma. So again, to be true, I was also very much worried, because the patient sustained all such chemotherapy. He attained remission just 9 months before. And again, one more DLBCL presenting as relapse without any B symptoms was quite uncommon. Again, the immunohistochemistry again it proved to be DLBCL. So now the diagnosis is nothing but it's a DLBCL, which is presented as a primary cardiac lymphoma. Why I am saying primary here is that because there was no other involvement anywhere in the system, like only the cardiac pathology was there. So now what happened? Now the patient underwent, and after that he lost to follow up. Like now we are just concerned, like we just have a calling with him, like what was happening. So he basically patient underwent like intensive chemotherapy, and he is planned for a stem cell transplant. So in coming to my fifth case, again this is we come across very frequently here. Like basically he's an elderly gentleman who was referred from a Master Health checkup. Basically the patient just had incidental leukocytosis. The counts was close to somewhere around 1.7 lakhs. So otherwise, and again poking, we had a mild history of malaise, abdominal distension was mild. Otherwise there was nothing else significant like symptoms or signs. An examination wise, he also had like diabetic and hypertension, which was well controlled. On examination, he had a spleen, a huge spleen palpable around 8 centimeter. So this was the if you see the laboratory values, so the WBC count was close to 1.5 lakhs. Again, now the patient, other cell lineages like hemoglobin was normal, the platelet count was normal. Now we have isolated leukocytosis. How to proceed? So this is the peripheral smear. Maybe it's very easy to pick up from a peripheral smear point of view. If you see there's a full shift of left, like all the WBCs which are coming up, whether myelocytes, metamyelocyte, band forms, everything is there. So now the diagnosis is almost confirmed. It's like a CML, that is chronic myeloid leukemia. Again, for the other basic workup, there was high LDH and the uric acid, which was very high. Rest of the parameters, everything was normal, like RFT, LFT, everything was normal. So now we know it's a CML. So again, the bone marrow was done to confirm the same. Again, he suggested a possibility of MPN, this is myeloproliferative neoplasm, probably CML. Again, so basically now next comes a twist here. Like basically the CML, as we all aware, it's a BCR-ABL mutation should be there. So we send a qualitative assay. And again, to a surprise, it was negative for all the 3 transcripts what we commonly come across. Like usually we do 3 transcripts, like P110, P230 and 190. So everything was negative. Again, now it's a doubt. It could be CML negative, like a BCR-ABL negative CML. So again, but we asked for a karyotyping. Now there's a clear-cut translocation, that is a 9:2 translocation, which is almost every time happens in CML. So now there is the translocation which is there, but it is not picked up in other transcripts. Now we don't know why. Again, we like because the molecular testing is not done in Coimbatore, we have sent it outside, outsourced, and it went to some other lab. And again, I spoke to the pathologist, molecular pathologist over there, because there is a clear-cut CML history, everything fits into CML, but we are not able to pick up in BCI-ABL. Why is it that? Like again, she also kind of think, okay sir, we will do further testing. So she did a Sanger sequencing. That means she has sequenced the entire genes over there. So now, to a surprise, there was a breakpoint. That's why there was a translocation, but that is, the breakpoint is not commonly reported. That is not reported in literature so far. So there was a breakpoint in if you see that E13A1 instead of A2, because most of the time we pick up only that A2 transcripts in like P210 or 190 or 230 transcripts. That was not picked up in a routine BCI-ABL what we have seen. So again, we have started on the conventional TKI, that is imatinib, and then she is responding very well. So she is again on regular follow-up without any sort of complications. She is doing very well as of now. So why I am saying is that we always have an insight of what is happening. We should always think in terms of clinical scenarios. Just because the lab has given us negative, we should never take it as negative unless proved otherwise. So again, I'm not going to CML detail per se. So CML always had a close duty with the leukemia reaction, which commonly happens in infections. So there will be subtle number of changes, which usually there won't be any base of flares which will happen in CML. So coming to my last case, again, this is again one sort of nightmare where we came across. Is a 36-year-old gentleman. He is a police, some SI or something of occupation. He again admitted with fever, loss of weight, appetite, easy fatigability, malaise, and gum bleeding. So that was a common symptoms. Again, any sort of hematological problem can have such symptoms. Only glimpse area that he had a gum bleeding. That means he should be having severe thrombocytopenia. So as expected, the hemoglobin was 6.9. The total count was in the normal range, like it was 5,000. But the platelet count was too low, that is 11,000. And if you see the differentials, which we always have to think in terms. So whenever we see the total still a normal count, we just not like we cannot take it as granted just like that. So we did the differentials as usual. There was a difference in poly and monocyte if you see, and there was again other parameters were within normal limits. There is a high LDH, which can happen in any sort of hematoloid malignancies. So now the peripheral smear showed blast. Yes, now it is acute leukemia. So next thing is that again, what sort of leukemia is that? So again, the differentials was like there is some acute leukemia. It could be still because there was a bleeding with a low platelet count. It could be APML, that is acute promyelocytic leukemia, or APML. Now the abbreviation slightly changed. So the bone marrow was done. Again, I got a call from Sedu sir saying that it's AML, but I cannot rule out completely APML. So APML is one disorder which is completely curable. It's not like AML. The initial 2 weeks will be very risky, but still, if the patient has crossed the 2 weeks of time, he will be as normal as everyone. So again, the flow settlement was done here, which again showed acute leukemia, but it was not significantly saying it as whether it's APML. There was some suspicion for APML. So again, he suggested for FISH testing. So FISH is nothing but the fluorescent in situ hybridology, like it was sent outside. Again, it came as the PML RARA positive, which is again which fits in towards APML. Though cytogenesis was also sent outside, which was showing a translocation 1517, which is common in APML. Only then we will be diagnosing APML. Now the diagnosis is confirmed. So we have started on conventional chemotherapy, and usually 80 to 90% of times, once the chemotherapy is started, the patient is going to be fine after a couple of days. But this patient, to a surprise, this was the count. If you see it was completely 0. Like he had a prolonged neutropenic phase. The WBC count never crossed. At least for span of 15 days, the WBC count never crossed more than 100. More than 100, it will be like somewhere around 100 to 200. So the total count, it was not surprising to us, because the APML never behaves in such a way. So the patient had a prolonged neutropenic phase, and this was his fever pattern. It will be like to be true, it was very scary. So if you see all these are organisms which he sustained during a period of time. Every time we get a call from microbiology saying that this organism is there, and sustained Pseudomonas, Candida. Next, every other culture show different other organisms. Again, after all this bacterial, next comes the most dreadful part, it's the fungal. Again, the CT was done because to rule out any sort of infections. So he underwent a CT which showed angiogenesis aspergillosis. So again, which can happen in AML, but it's very unlikely in APML. So again, it was aspergillosis which was treated with the voriconazole, and those are the days, like it was 1.5 years before, where and the ID opinion was like Ripamadan was not available, so we have to treat all alone. Like we had a discussion with other departments like pulmonology and radiology to see what sort of disease it could be, what other infections could be. Again, so patient basically was all these neutropenic phase was there. On day 21, again he was complaining of some tooth pain with the cheek swelling. So there was pus formation in the second and third molar. So again, the MRI was taken, which showed diffuse marrow edema, and again, I think I got a call from a radiologist department saying that it could be some mucormycosis. Now it's a kind of nightmare for us, because we all know mucormycosis is an extremely bad thing, which we can, it is very difficult to treat. So I'm not sure how much we are able to appreciate. This is the suspected mucormycosis which was there. So and he underwent CT and MRI imaging, which fits in towards mucormycosis. Now again, our neurosurgery, like Vikram's opinion was obtained, what to do next, and the maxillofacial team was also obtained. They suggested because there was a suspected mucor, and before all these things, just because we got a call saying that there was a suspected mucor, we straight away started him on liposomal ampho, which is the drug of choice. So we opted for right partial maxillary alveolectomy with the face clearance. So everything was well, surgery went on well, and he was promptly started on liposomal ampho. And currently everything went on well after sustaining all such complications, all such infections, all such fungal. The patient is now currently in remission, is on close follow-up. So why I am addressing is that because hematology, we always thank all the departments. It's a multidisciplinary approach, because without their help, without their inputs, we won't be able to treat any such infections. Say it is microbiology, or say it is biochemistry, because we always try to call and find out what is happening at the laboratory level. So again, because of the warrant of time, I have stopped all my further cases, and this will be my take-home message. So hematology is all about the multidisciplinary approach and the teamwork, and we always treat patients and not the lab values, because just because the lab value has come in a different manner, whether it is high or low, we don't treat that lab values. We will always try to find out, is there any actual requirement to treat the patients or not, and no single value is usually reliable. We have to look for the trend, whether it is going uptrending or downtrending, and always try to treat that. And again, as far as common things say, like anemia is common in India, like most of the time, predominantly 70 to 80% is IDA, iron deficiency anemia, but not every time. Because we do have many patients with hemolytic anemias, we do have many patients with thalassemia. We have picked up patients of thalassemia at the age of 74, to be true. So nowhere, no one has evaluated what was there, and all these time the patient was given some iron tablets, ferritin and all, and finally this patient ended up in iron overload with thalassemia. Again, there was a patient who had a PRC, that is pure red cell aplasia, which could also be there. So other cause of anemia should always be ruled out before starting any sort of therapy. That's why we generally do. Sometimes we got a complaint that we are doing many lab tests, but unfortunately without that we won't be able to diagnose anything. Again, not all thrombocytopenias are ITP. Again, even now there is a patient who was treated as ITP outside from a very good hospital here 2 days before. So the platelet count was only 21,000. Just like that they were started on steroids without even knowing what was there. And finally bone marrow was, now it is APML. Again, 2 days before we discussed, it was such an interesting case. Now again the patient is started on chemotherapy. So why I am saying is that not all thrombocytopenias are ITP. Again, all ITP is always the diagnosis of exclusion. So without diagnosing, like without ruling out other causes, we cannot diagnose ITP per se. So peripherals may always gives a good lot of information, and not all the patients with hematology will require bone marrow. Yes, there are set of patients who will require a bone marrow, but not every patient will require a bone marrow. Based upon clinical scenario, she may be requiring the bone marrow. And I will be happy to take up any questions for that, and thank you for that.
After an elaborative session on 6 cases, like so sir said, like he had images which are less interesting. I have numbers for you, so it'll be. Please try to stay awake. I think it'll be useful at the end of the session. First, I'd like to ask a question. How many blood transfusions happen in India every year? I don't think anyone can give an exact number. Even I'm not sure about the number, how much it is, but the Ministry of Health and Family says that it is 1.46 crore blood transfusions which are happening every year. This is of 2023. So, blood transfusion, when and where in a hospital, more blood products are required. So, usually it is in the emergency department where they face, in case if they receive any trauma patients, they might require more blood products at the place. And also in the intraoperative period during surgeries, many vascular surgeries or major transplant surgeries, neurosurgeries, so they might require more blood products. And also in the obstetrics department when they face with peripartum hemorrhage. So vigilant usage of blood is very important. Decreasing demand will help improve the care of the patient and also the availability of blood products for other patients. But how to do it? One is like we can set protocols, set transfusion triggers, and also have advanced investigations to find a probable reason for the bleeding. So I think every one of us will be more familiar with this coagulation cascade, which says the intrinsic pathway, extrinsic pathway, and common pathway. So the coagulation, we do tests of coagulation to test the coagulation parameters. So first is a conventional coagulation test in which we do the prothrombin time, INR activated partial prothrombin time, platelet count, D-dimer, etc. And the newer ones are like point of care coagulation tests, the TEG and the ROTEM. It's actually not new. I think we'll get to know with the future slides. The TEG was actually invented in 1940s, so it's not really new. The problem with the conventional test is like the PT, INR, APTT do not represent the complexity of hemostasis. Either the platelet count also. It provides information on clot initiation, but it does not have any information on clot formation or fibrin polymerization or like even fibrinolysis. So that's where TEG and ROTEM comes in. As I said, TEG was developed in Germany by Professor Hartet in 1948, and TEM Innovations were the people who invented it. And the coagulation status, initially it was developed for trauma patients who bleed more and to check the parameters and lab facilities, like they did it for military patients and emergency situations. ROTEM is based on technologies of TEG, assessing the viscoelasticity properties of blood clot. And even that was invented in 1995, that's nearly 30 years. So there are two ROTEM machines, the ROTEM Delta and ROTEM Sigma. Not a big difference between the both. We have ROTEM Delta, and we are the only center in Coimbatore which have ROTEM at present actually. ROTEM Sigma is like a advanced version just to avoid human error, no big advantage over the ROTEM Delta. So coming to my topic primarily, I'm going to talk on ROTEM, shedding light on coagulation dysfunction. So first, what we do, how do we test for ROTEM? The principle is very simple actually. We collect the blood in a citrated sample, we take it, they have a cuvette and a pin setting. We add some reagents, activators or inhibitors, and then we put the pin in and it is rotated right and left. As clot forms, the pin movements gets restricted and it is integrated into a computer calculator and it given as a report as a ROTEM. In case if we didn't understand, to make it more simple, like so the older version say, if you have curd and to make buttermilk and butter out of it, the old lady sits and they go up and down, the same rotational motion of the pin, and the bottom cup stays still. So as the butter gets formed, slowly the resistance increases and it leads to changes in the lady has to put more workforce. So it is similar to that. We do test, and once the clot get formed, there is resistance to the motion of the pin, which changes and it is depicted as a graph. So before going into the details of normal and abnormal ROTEM images, I'd like to say a few words on tomography, that is the graph. So once we put the blood and we put the reagents, we get the report as a graph. So what that graph means and what are those points there. So in the x-axis we have the run time, that's the time in minutes, and the y-axis we have clot firmness. So as we see at the top, the coagulation factors, anticoagulants, FTPs, tissue factor expression, everything comes in the first part of the rotum, followed by the platelets, fibrinogen, and later part is the fibrinolytic enzymes activity. So there are three, like initial two components are CT and CFT, which are the coagulation time and clot formation time, followed by the angle, alpha angle, and then followed by A5 and A10. All these numbers which are represented next to the alphabets are the time. That is A at 5 minutes, and next is A at 10 minutes. And MCF with the maximum clot firmness, and then next phase is lysis. In case if there is lysis, there will be decreasing in the size of the clot firmness, and we do a ratio to compare it, which will be explained in the next slides. So it's the same thing. The pin is rotated by a spring alternating right and left. As the clot forms and strengthens, it exerts an increased resistance to the rotating pin, and that is depicted as the graph. Explaining the parameters, as I already told, CT is the clotting time. That is the time which we initiate the test. So once you put the blood in the cuvette and we add the reagents, then as soon as we add the reagent, the clotting starts. So the time until the initiation of fibrin formation and the clot reaches 2 mm of diameter. So when the clot reaches 2 mm of diameter, the CT cuts off. So till then is the clotting time. Clot formation time is the period between 2 mm to 20 mm. So that's the next advanced level. Third one is the angle. Angle is a tangent drawn at 2 mm of the clot firmness. Maximum clot firmness, that is the greatest width achieved, which is tracing reflecting maximum clot strength. Next is the amplitude, which is at 5th minute, 10th minute, and 20th minute. And MCF is the maximum limit. So it will be like 60 minutes if we run the test. So usually around like 30-40 minutes we get the maximum amplitude. That will be the MCF. Lysis index is lysis 30 and lysis 60. That is at 30 minutes and 60 minutes. What's the lysis factor? So that gives information about the clot stability and fibrinolysis. There are different types of rotum. Like so, we have extem, intem, fibtem, aptem, and heptem. We also have some more types. Just sticking onto the minimal basic information regarding rotum. The extem, as the name suggests, it is the we assess the extrinsic pathway. Intem, we assess the intrinsic pathway, and fibtem is we assess the function of the fibrinogen, excluding the platelet function. And we also have aptem. Like in case if there is a fibrinolysis, we add aprotein and check whether the fibrinolysis gets corrected. And heptem is the heparinase term. In case the patient is on a heparin, if you want to check the activity of the requirement of protamine is there, we do an intem and we add a heptem and then we check for it. So there are different reagents. As I said, there are many more analyses. Like in case rotum platelet analysis also available currently. That is like aratem, the arachidonic acid TEM. In case you want to find platelet dysfunction, if the patient is on aspirin and is it gonna affect it? Like so, for that we have to do aratem, adaptem, and traptem. For now, we'll limit to the rotum delta things, namely extem, intem, and fibtem. So coming to extem, so as you see, we collect the blood in a citrated sample, and the reagent we add calcium chloride, and the recombinant tissue factor we activate the clotting. In case if there is any deficiency in the extrinsic pathway, or if there is any problem with the vitamin A, vitamin K anticoagulants or a directly acting anticoagulant, there will be an indication for FFP transfusion or prothrombin concentrates. Fibtem, what we do is like we do act the tissue factor and activate the coagulation, but we add a cytocalcin D. So that what the cytocalcin does is it inhibits the activity of the platelet. So we get the activity of only fibrinogen. And next coming about intem, we add ellagic acid, and that helps in finding the intrinsic pathway deficiencies. So how does a normal rotum look? So this is the normal rotum looks. So two things. One is the graph. The graph itself gives us lots of information. One is the green line. The green straight lines which are there here in the extem and fibtem gives you a rough mark. So just by looking at the graph, we would say if the graph is above the green line, we would say that the clotting factor is better. If it is too much high, it is like hyperfibrinosis, hypercoagulant rotum. And in case if the graph is below within the green line, that says that it is hypocoagulable. And this is the fibtem graph, and the fibtem graph also says the same. Along with the graph, we also have the numbers. So there are too many numbers here, but the values will be printed as any lab report. So we'll have the range to compare also. On average, the CT is approximately around 30 to around 80, and CFT stays up to 160, and the other numbers as mentioned. So coming to abnormal rotum images, there are we'll just look into hyperfibrinolysis and fibrin polymerization disorders. First thing is fibrinolysis. So you can see here the clot formation was okay, initiation was good because the CT time is 69, which is within the range, and then you can see the A5 and A10 are also within the range. But after some time, there is initiation of fibrinolysis, and you can see the tailing off of the graph. That means there is no problem with the clot formation, but there is lysis, fibrinolysis, which can be seen in extem. What they have done is they have done an aptem. Aptem is they add the upper and then check, and we could see that the graph gets corrected. So we can even check for the response of the treatment what we are going to give. Next is fibrin polymerization. The other way around, if you look at the extem which is low, we can see the graph which is green color, which is lower than that, and the A5x, the A is the amplitude, phi is at 5th minute, and E is at extem. And the same here, FIB means fibtem. So the different reports with different numbers. So if it is less than the normal values, so that means there is fibrinogen deficiency. And next, coming to thrombocytopenia. Thrombocytopenia, in case there is severe platelet dysfunction, and you can see the to differentiate between hyperfibrinogenemia and platelet, if you do a fibtem, and if the fibtem is normal and only there is abnormality in the extem, that means we have deficiency in the platelets. Either platelet, it might be number or it might be functional, either, but we have to correct it with the platelets. Next, in case if the rotum is hypercoagulable, how to find it? In case if we do a rotum, the numbers will be lesser than the normal ranges. So hypercoagulability detection during lab parameters, it will be very difficult. We can check it through rotum. So important considerations before analyzing, as sir insisted, we don't treat lab numbers, so we have to check. So it does not answer the question whether the patient will bleed. It gives insight to why the patient bleeds, and the first question always is, does my patient has diffuse bleeding? If the patient does not have diffuse bleeding, the analysis ends there. There is no need for rotum actually. So the indication is indirectly told that when there is a diffuse bleeding, then we'll have to check it. So always don't treat an abnormal rotum in the absence of clinical bleed. If the clinical bleed is present and we have an abnormal rotum, there we have to intervene. So going into algorithms, I have 2-3 algorithms just to discuss about the different case scenarios. So there is a trauma algorithm. So this is the algorithm for trauma. So there are different algorithms. Mainly they have concentrated into trauma. They have algorithms for obstetric hemorrhages. They also have algorithms for transplant surgeries. So we'll break this algorithm into different parts. So first thing is the clinical situation. They analyze the clinical situation, and next they look into hyperfibrinolysis, and then the clot firmness, followed by thrombin generation, and then we can reassess the situation. So first thing, so when there's a severe bleeding in trauma, first we have to assess in the emergency room. We'll have a blood gas, so we can have information about the hemoglobin. If the hemoglobin is less than 10, or we have basics of more than -6, and then we have a trauma score of more than 15 and ISS score more than 25, indicates the need for tranexamic acid. Up to 25 mg per kg can be given as a single bolus. If not already given as prophylaxis, can be initiated then. But in case if there is none of these, but still in the trauma, we check the rotum there, and we get the reports. As you see, once you collect the blood sample and then you initiate the rotum test, when you run the rotum test, at 5th minute we'll have the values whatever is asked here. So A5 in the extem, when it is less than 35, or the CT of the fibrinogen, fibtem, is more than 600, or the lysis is more than 5%, that indicates tranexamic acid again. So in case if you are not given through this path, if these parameters are checked, then we have to go ahead with tranexamic acid. And if there is none of these above, we go to the next step. We check for the clot firmness management. So in that, we again check for the A5 extem. So A5 extem is if it is less than 35, that is the normal range. And if the fibrinogen is also less than, A5 fibtem is also less than 9, then we have to give fibrinogen concentrate or cryoprecipitate. Again, arranging for once the patient received in the trauma in the ER, and then if you send the test and within 10 minutes if you are able to diagnose, availability of products and many things are also involved in this. So in case of the cryoprecipitate, there is a delay, we can start with fibrinogen concentrate, and once the blood products are available, we can replace it to that. So how to calculate the fibrinogen doses? Say, so in case, it depends on the level of the size of the A5 value of FIPTEM. In case the value, if you have to raise it by like 4 or 6 or 8, depending on the number. If 9 is normal and we have 2, if you have to raise it by 8, then we have to go somewhere here. So this is like 4 gram for 80 kg adult. So fibrinogen concentrates are available in our hospital. So it is available in 1 gram for like each container. So we can provide it. In case if there is requirement of 4 grams, you have to give 4 vials. Or if we have a cryoprecipitate already ready, then we can use like say each unit will be around 5 ml or 10 ml if you keep approximately around 250 ml of cryos required. Next, coming to clot firmness management. Provided that the fibrinogen level is normal in FIPTEM and the patient still continues to bleed, then the patient will require platelet. Like how to prove it? Like we have a FIPTEM value of more than 9 and we have an EXTEM value of less than 35. Or platelet dysfunction. In case if you suspect platelet dysfunction, the patient is on antiplatelet therapy and things, then we can do ADP-TEM and TRAP-TEM. But at present, we don't have the facility to do it under hospital, but other things we can do. In case if it is so, then we can do platelet transfusion, 1 or 2 pooled platelets or SDP if it is available. Next, coming to coagulation time management. In case if the CT is prolonged, the CT is the first thing which we get. If CT is prolonged, if it is more than 80 seconds, that means it warrants transfusion of coagulation factors. So it can be given in terms of FFP 10 to 15 ml per kg or like prothrombin concentrates like 15 to 25 units per kg body weight. And if none of these are there, and if we suspect patient is on heparin, and if you want to check that, we have to do a INTEM and HEPTEM. We can do a ratio of CT, and if it is more than 1.5, it warrants treatment. If that says no, then we can give FFP. If it is so, then we have to reverse it with protamine. If it persists ongoing bleeding, then we have to recheck the sample. There might be sample error also in case. Then we have to recheck with a new sample. So this is the protocol for trauma, and for obstetrics, we'll just rush through this algorithm. We have if you have a hemorrhage and if there is a blood loss of more than 500 ml for vaginal delivery or like cesarean delivery more than 1000 ml or 1500 ml in severe blood loss, the woman trial suggests to give tranexamic acid within 3 hours after delivery. So there we run a ROTEM and we can find similar with A, EXTEM at 5th minute less than 35 or CT of FIPTEM more than 600 seconds and lysis more than 10%. The lysis factor varies between like the trauma scenario and the obstetric scenario. And if there is signs of lysis, we give tranexamic acid, and if there is no indication for tranexamic acid, we come down the algorithm, and then if we see the FIPTEM again, if it is less, we go with fibrinogen replacement, and if fibrinogen levels are normal, we go with platelet replacement, and further after that we transfer to the FFPs and things. We have to make a note of it whenever the patient requires fibrinogen, like the FFP transfusions. When we give 10 to 15 ml of FFP transfusion, even though the fibrinogen levels might be normal, it might get diluted, and the patient might ultimately require fibrinogen concentrate or cryoprecipitate transfusion. The last one is like again in case of heparinization, how to treat it, and if there is ongoing bleeding, always recheck and you have to treat. So this is a small case scenario explained. So this is a case scenario of PPH. This is not our case series. This is taken from online. So there was a postpartum hemorrhage, and ROTEM was done after activation of anesthesia team. This is the timeline. This was done at 12:54 noon. They have done the ROTEM, but you could see there is already a deficiency of fibrinogen. The A5 value is only 3. The normal value is more than 9. So if it's 3, there is already a deficiency. You can see CT, there is a mild prolongation. CT, as I said, the normal value is around 79. It's 137 already. But unfortunately, the patient was not treated at this point. They repeated a ROTEM at 152, that is 1 hour after the initial value. You can see the significant difference what happened to the previous value. There is a significant loss, obviously the expected loss during the postpartum hemorrhage. You can also see the lysis. And FIPTEM, there is no trace picking up, there is just a flat line. So we have lysis and also a flat line of FIPTEM. So we have to treat both. We have to give fibrinogen along with tranexamic acid also. So once we give it, they repeated it after like say 40, 20, 30 minutes, and then we could see there is slight improvement, but still you could see there is a deficiency of fibrinogen and platelets also. So we need not wait for the other things to get corrected. Once you correct, we can recheck it immediately and we can get the other things. So after that, another 40 minutes, they repeated, and then the patient clinically improved based on both correction of coagulation and the surgical management, whatever the patient underwent. So to make it simple, in case it was too exhaustive, we'll make it simple. So in that, how fast the clot starts to form. So to answer that question, CT. If the CT is prolonged, it's indicating of delayed clot formation. That means it requires FFP or PCC. In case if that is normal, then we go to the next thing, which we look at the MCF. So if MCF is too low, that is indicating there is a weak clot. The clot formation is okay, but the clot is weak. So what we're going to do, we're going to transfuse either fibrinogen or platelet. So depending on the FIPTEM values, we'll be able to decide on whether to give a cryo or to give platelet. Next is how long the clot is formed, but the size is okay, but after some time the clot is getting lysed. So for that, if there is too much of lysis, then we have to give tranexamic acid. So this is the shortest form of Rotem in case we want to make it short and quick. So why we are more interested in this? Complications, we know that complication related to blood transfusion is high. We know TRALI, we know TACO, we know TRIM. These are all not new terminologies. And these are the major contributions of mortality in any patient who is requiring a transfusion. Massive transfusion is a well-known factor leading to causing morbidity and mortality. And moving forward from ratio-based, which is the gold standard, they say ratio-based 1:1:1, we transfuse. We are slowly moving towards patient-based management. And the traditional ratio-based transfusion still holds good until we get those reports. So it just gives us some time to identify the reason for exact bleeding. And once we know the reason for bleeding, we need not stick on to the 1:1:1. We can go back to the Rotem-based therapy. Adequate hemostatic interventions to stop bleeding is also very important. Patient-based blood management is the timely application of evidence-based medical and surgical concepts designed to maintain hemoglobin concentration, optimizes hemostasis, and minimizes loss in an effort to improve patient outcome. We all know time is life. Turnaround time, this is standard turnaround time anywhere in all over the country. It's on an average, the standard lab test takes around 60 to 75 from the time you collect the sample. But the point of care, in case if the machine is available at that point, you'll be able to get a report at 5 minutes. We'll be able to assess the coagulation status. We'll be able to activate the blood banks early. We'll get the products early, and we'll be able to initiate the treatment early. Has superior results in predicting the need and adequacy of transfusion than compared to the point of care tests, reducing transfusion requirements, healthcare costs, and complication rates. The cost of testing might be slightly higher than point of care tests, but when you consider the overall outcome of the patient, hospital stay, requirement of blood products, transfusion, and complications arising from transfusion, there are many studies stating that it is advantageous over the other one. And the main areas of requirement of Rotem are usually critical care, trauma, obstetrics, transplantation, and anesthesiology department, and it helps a huge way to our department in liver transplantation. The only thing is, like, we should appropriate therapy only will stop bleeding, not just transfusion of products which help in coagulation. So before treating patients based on Rotem, it is better we understand that Rotem algorithms are mainly, it's not to do algorithms. Like if we see the fibrinogen levels to be normal in the Rotem, FIPTEM is normal, there is no need for fibrinogen. So it is the main thing which it tells is avoid what is not needed. That is more important. And there is a very, very important factor, like without this, there is no point of care coagulation test, there is no Rotem. So in case if everyone stops blood donation from tomorrow, there won't be anything related to it. So blood donation is the very important factor. Blood Donors Day we had in June 14th, and the 2024 theme was like 20 years of celebrating giving. Thank you all the blood donors. Continue to donate and save lives. Thank you.
And I'm also very happy to be part of this initiative called SRH Academics. It is just helping a medical person giving associated paramedical persons the basic awareness of a medical knowledge. That's a basic thing of starting SRH Academics. Okay, what I'm going to talk today is about reality in fertility. Considering fertility, most apart from doctors, all the fertility topics has been discussed by a non-medical persons only. It will be maybe grandmothers, mother, and then YouTubers and other alternative medicines like Ayurveda, Siddha, they all come into this fertility issues and they discuss more on this fertility issues compared to a medical doctor. So we should know exactly what is happening in the current generation about this fertility aspects so that we have a better clarity and also even guide our own children and our own colleagues and our students as well. So what I'm going to discuss today is majority on 4 topics. One is during puberty, which is dealing with polycystic ovaries. Every other girl, they walk into our clinic with the problem of polycystic ovaries. So I thought we will definitely go ahead and then talk about this PCO. Second thing about the female reproductive status, because currently a lot of late marriages and then elderly conceptions we see. So what is the actual scenario of female reproductive status? We should be knowing about it. And then comes the male reproductive status. In our country, not even in our country, globally what they think is male is always fertile, male is always fertile till lifetime, but that is not so. So we have to educate the crowd as well as the male that even they age, even their reproductive status age. So let us discuss even on male reproductive status. And the fourth comes about the myths in fertility. So lot of myths has been going around in about conception rather than the real facts. So this is how I'm going to classify my talk today. So going on to puberty, that is PCO. This is a very common issue in the adolescent age group. Commonly from pharmacy college, in our SNR, from SNR Women's College, girls walk in, they call themselves as a PCO patient. That is what the new current trend, current name, like Gen Z, what we call Gen Z, isn't it? They come to us, they say, Madam, I'm a PCO patient. What is PCO patient is? Polycystic ovarian patient. That's what they term themselves as. We have to stop this right from the when they start this, we have to just shut it down. We can't ask them to call themselves, brand themselves as a PCO patient. But what is PCO? It is called polycystic ovarian disease, or it's called as polycystic ovarian syndrome. Actually what it is, we have to understand. Okay, let me talk about this PCO for 3-4 slides. Hope you can understand this and travel with me along with this. See, a PCOS is the most common metabolic abnormality in young women today of reproductive age. Most common cause of infertility in women, what we see is PCOS. Studies of PCOS in India reported a prevalence of 3 to 22% up to 36% in adolescents. That is, out of 100, 30 to 40 girls will have PCOS. We have to understand this. It's such a common problem. It is not very abnormal problem, it's very common problem. Why does it happen? Why only we have the PCOS? Why girls have PCOS? A large number of genomic variants has been associated with PCOS, and many of these associations have not been replicated in different population. That is, Indian PCOS girls will have a different genomic variant, and UK girls will have a different, US girls have different, African continent has a different. So different races have a different genomic variants. So the girls cannot be treated the same as in India as well as in US. It's not the same criteria, it happens in all continents. It is believed that the picture is of multigenic etiology in which non-genetic factors such as diet and exercise also have a strong influence. So what this slide definitely proves is PCOS has a genomic variant which differs in different continents, and also a non-genomic variant which is their lifestyle, which is absolutely diet and exercise. So it is influenced by both genomic as well as non-genomic. What happens when these girls have a PCOS problem? First, they have a menstrual dysfunction. What sort of menstrual dysfunction they have? They have oligo or amenorrhea. What is oligo? Oligo is they won't menstruate every 28 days. They'll be menstruating only by 35 days to 45 days. So like every 1.5 months, they'll be having their periods. The second one is amenorrhea. That is, they won't even bleed, even for 3 months, 5 months, or even 6 months. We commonly hear that. They attain puberty around 12, 13 years, and the mother will come and say after 6 months she had another periods, and after 1 year, even after 8 months. So that is how it's called amenorrhea. So they will have less frequent cycles of their menstruation. And the reduction in this ovulatory events leads to deficient progesterone secretion. What happens exactly inside their system is because the ovulation is not happen on the 14th or 15th day of your regular menstrual cycle, the estrogen and this progesterone hormones will have a variation. So they have all the negative effects of hyperestrogenism. So what we have to do is this chronic estrogen stimulation of this endometrium with no periods for 1.5 months or 6 months or 8 months is not good, because this chronic estrogen stimulation of the endometrium with no progesterone results in intermittent breakthrough bleeding as well as increased risk of endometrial hyperplasia. So what we have to understand is, if they are not bleeding regularly, if they have a periods for about 3 months or 6 months, they have to be brought to the doctor. It is not that they are not supposed to be meeting a gynecologist, because when they don't bleed regularly, their estrogen content will be very high in their blood system. Those estrogens is really harmful for the uterus, which will lead to endometrial hyperplasia even at the younger age. So what we have to advise the parents as well as the staffs here is, they have to bring the kid or advise your students to come and meet the doctor if they don't have a regular menstrual cycle, because we have to start the treatment right at the early age to avoid any complications in the future. So how do they have? This is little bit of hirsutism they will have. First is menstrual dysfunction they will have. Second is hirsutism. This sort of hair distribution they will have. Little on the cheek, little on the side, and then little below their chin they'll be having minimal baby hairs. They'll call it as baby hairs, and they'll be happy about it. These girls will say, I have got baby hairs, I have not grown well, I have small tiny hairs, but that's not a good sign. So this hirsutism, we have to pick it up early. And this acne is acne is very common at the young age, but if they have severe acne, this is also a symptom of PCOS. And the third thing is baldness. There will be a little bit of frontal baldness. There will be a near edacrolia, and the near update it goes wide. So that is not the correct sign. That is the first sign of this PCOS, which is getting into real problem. It will have lot of metabolic disturbances when all these symptoms have start occurring for these girls. And then little bit of male type of hair growth below the umbilicus. The small hair everybody should see below the umbilicus till the pubis. Absolutely there should be no hair for girls. If there is little bit of hair of this sort, even this is an early sign. And this is called acanthosis nigricans, that is on the neck. There will be darkness on the neck. So commonly we attribute it to our gold, or maybe it is some other non-gold ornaments if you wear. It is allergic to those ornaments, and then we keep putting kadala mavu and all that stuff, we see girls doing that at home. But this is an earliest sign of proper metabolic dysfunction. This is called acanthosis nigricans. So when girls have this acanthosis nigricans, this type of hair growth, acne, this frontal baldness, and this hirsutism, and with menstrual dysfunction, all these 5 or 6 symptoms, they have to start their consultation little early. It is going to be very few consultations, but those few consultations is going to catch them at early stage, so that they will not get into fertility issues when they get married after 23 or 24. Okay, this is about PCOS. So diet and exercises plays a major role in controlling PCOS. Compared to diet, and so the common question is, what diet to follow, how much exercise to do. This is a very basic question. It doesn't go hand in hand to all girls when they come. It varies with each individual. So every diet and exercise should be individualized, concerned with their capacity to diet and capacity to exercise. If some girls can wake up early in the morning, they can do exercise. If they can wake up in the night, they can do diet. They can control their diet in the night. So it is more individualized. So if we come to diet and exercise, a moderate amount of daily exercise, what it does is, it increases the level of insulin growth factor 1 binding protein, IGF-1 binding protein. There is one protein which is in the body, which increases that protein, thereby decreases the IGF-1 levels by 20%. That helps them to reduce their weight. So that is why the exercise, moderate amount of exercise is absolutely mandatory to have a control of our syndrome. And modest weight loss, how much of weight loss you need, whatever weight you are, like you say 50 or 60 or 100, but moderate weight loss of about 2 to 5% of your total body weight can help restore your ovulatory menstrual periods in these patients of PCOS. Even if you're 60, you have to cut down your weight by 5% to 10%. 10% is 6 kg, 5% is 3 kg. So we are not asking more. It is only 5 to 10% of whatever weight you are. 100, only 10%, which is 10 kg. 90, 10%, 9 kg. So you are not going to achieve 15 kg or 20 kg. But 5 to 10% of your total weight, if you cut down, all your metabolism will become all right and your ovulatory function will be retained. So future fertility will not be an issue. That is how this weight loss with exercise will help. And then coming to diet. How do you maintain your diet? A daily 500 to 1000 calorie deficit with 150 minutes of exercise per week can cause ovulation. What does it mean, like daily 500 to 1000 calorie deficit? Whatever calorie you take in, if you take 1200 calorie, you have to burn 1300 calorie. That is the idea. Just to make a little, for you to little understand, see if one idli is 40 calories, but one puri is 120 calorie and one bread is 120 calorie. That's why we have to cut your calorie intake every day. And your routine activity, like you're taking bath, you're having, you're sitting, you're standing, you're walking, and then you're brushing your teeth, all those activities will cut around 700 to 800 calories per day for any normal individual. But what we eat is, we eat about 1400 calories. So where do we burn the extra 500 calories? That's why we are not able to reduce our weight. And if you walk about 5 kilometers in 1 hour, you'll be burning around 300 calories. Okay, that is about 2 bread. So if you're going to, that's how you have to count your calories. From morning, you have to put a chart. Okay, you have to put a chart and write down what are the calories you're consuming and what are exercises you're doing and your routine activities. And if there is a calorie deficit of 500 to 1000 calorie, drastically your weight will come down. These are the little tricks of, getting your diet and your weight loss. So even 5 to 10% of your weight loss will help to correct your PCOS. So that's when you have to concentrate. So in this adolescent PCOS, why there are more slides on the adolescent PCOS is the long-term issues is really bad. They will have a lot of insulin resistance. When they turn 40 and 50, they will have cardiovascular risk. They will have obstructive sleep apnea, insomnia, that is sleepless nights, and then there is high risk of malignancy. So you start at 17, 18 so that we don't get into problems at 40 or 50. So this is about this PCOS. So what this slide about PCOS, what we should understand is we have to start at 17, 18 years, even at the school age. If they are not regularly menstruating with your friends or with your colleagues or with your students or with your neighborhood, please ask them to come to a gynecologist and then start this treatment early so that they will not have any fertility issues as well as the future risk. And then coming to the second point. Second point what I wanted to discuss was female reproductive status. So coming to real fertility and real conception. When do we call themselves, any girl, any lady, when do we call themselves as a infertile? Infertility is, it refers to inability to achieve pregnancy after 12 months of unprotected sexual intercourse with average frequency of 3 to 4 times per week without using any birth control measures. Why we are so specific in each and every word of this definition is, the common thing what we see now is they have intercourse on Sunday and then the next Sunday, then the next Sunday. So only 4 times in a month, which will definitely not help them fetch a pregnancy. So they should be having a frequency of at least 2 to 3 sexual intercourse every week, at least for 1 year, and still they are unable to conceive, then they are supposed to meet a gynecologist. How much pressure I gave on this PCOS to come early to a gynecologist to help themselves, that much leisurely I am going to give them when they are going to try their conception. So they have to try naturally at least 2 to 3 times per week, at least for a year. Still then if they are unable to conceive, then only they have to walk into a fertility consultant clinic. Usually this fertility issue, it affects 9%, that is 9 out of 100. If 100 are trying, 9 will need assistance for them to conceive themselves. It can be a primary infertility even for the first pregnancy, or it can be secondary infertility if they're trying for the second pregnancy. It doesn't mean if they have 1 kid and if they're going to try for the second kid, they're going to conceive as fast as they conceived for the first one. Definitely there will be a lot of issues in the meantime, so that the second one, if they're going to try, sometimes they'll be unable to conceive. So it's called secondary infertility. So the primary infertility will be around 70% and secondary infertility is about 30%. So the common thing is when they come for the second kid, they won't be able to accept themselves. Doctor, I had a delivery, I had an abortion, but why I'm unable to conceive for the second one? They won't be able to accept themselves as an infertile couple. But it can happen almost about 30%, they may be infertile for the second kid. In general population, 85% will conceive in the first year. That's why we allow the whole 1 year for them to conceive. and 93% will conceive in the consecutive year. Okay, they are not patients, they just want to try naturally. So almost 85 to 90% they can conceive. So the role of fertility consultant comes only for 10%. Only the 10% of the population will need help from us. So those 10% have to walk in early if they have issues. Okay. So what will be the causes? The causes why they don't conceive. When they come to us, it can be because of female alone, or it can be because of male, or it can be unexplained factors where everything seems to be normal, still some gamete problems, which is microscopical problems. So female factors usually dominate. It is about 50%, and male factors are about 35%. And unexplained, what is unexplained is, it is microscopical level where we will be unable to detect using an ultrasound or a blood investigation. That is called as 15%. So that is called unexplained infertility. So that will be around 15%. So 50, 35 and 15, it comes to 100%. So these are the causes what will be identified when they come to us to find a reason and then help them on that. 50% out of all this 100, 50% will conceive with such simple measures. Because hardly they will need any extra treatment for them. Only simple, just advise them, just give them certain medications, just do some ultrasound for them, give them some counseling, they will conceive. So there is a lot of hesitation to walk into your fertility clinic, to start themselves, even to analyze themselves. But they have to walk into a consultant room to know what is the counseling, because only with minimal treatment, 50% will conceive. Not all will require higher treatments. So we have to encourage them to who all needs, we have to encourage them to come into the fertility consultant room. Okay, so this one just to know. So how do we measure this fertility thing in India? We have a crude birth rate or age-specific birth rate, but the general thing is general fertility rate. So I just wanted to mention that general fertility rate is GFR, number of births per 1,000 women in 1 year of reproductive age group. So how much they conceive? 50 to 300 per 1,000. That is the volume of fertility rate in India. Almost 300 out of 1,000 will conceive. So that's a good fertility rate in India. Okay. So this is a volume. So we are not still into a lot of, as we say, diabetic capital. India is a diabetic capital, as you all know, because many of them are turning into diabetic. Still, India has not become into an infertile capital because there is a lot of deliveries happening. Still, we are very, very fertile. So we have to understand that. So if you're not getting conceived, we are just a minimal group. So we can always get help. So what happens? This is the reproductive status of a female. So what happens? Even though girls and women, when they achieve their puberty until menopause, they are regularly menstruating, they age. Their oocytes, as they age, their oocytes also age. Their egg also age. That is the one thing we have to understand. Because nowadays we see girls, ladies, coming after 45 years, they are regularly menstruating. The doctor, I menstruate every 28 days. Why not try for me? I can conceive. I have a huge confidence because I'm regularly menstruating. I have 4 to 5 days of cycle, and that gives them a false confidence that they will be conceiving very faster. But that is not so, because at birth, usually ovary will have about 1 to 2 million oocytes, and then at puberty, that is when they attain age, it will be only 500,000 oocytes. There is a depletion of egg. As girls getting older and older, there is depletion of eggs. It's from puberty, when they go into adult, that is around 25 to 30 years, only 300,000 oocytes they'll be left with. And out of those oocytes, every month only one oocyte is going to ovulate. All other oocytes, 10 million oocytes, will be depleting. So as it gets depleted and depleted and depleted, the age quantity, the egg quantity as well as quality, both will have a negative effect. So even at 45 years, even if they're going to regularly menstruate, their oocytes will be of 45 years and not of 25 years. When we take the oocytes from the girls and check it under the microscope, with the oocyte only we'll be able to tell this oocyte belongs to 20-year-old girl, this oocyte belongs to 30 or 40. Because that oocyte will have a hardened structure on the outer surface so that it will prevent pregnancy. So what we have to understand is, even though if you're going to regularly menstruate, as you age, as your chronological age goes up, your oocyte age also goes up. So you have to have your conceptions early and can't delay your conceptions. So this is a graph which depicts the ovarian reserve gradually decreases right from the age of 13 to 25. It gradually decreases at 30 and 35. It has a dip at 35. So a sudden dip. By 35, sudden there is a dip. From 35 till 50, it's very difficult to make the patients conceive. But before 35, it's very easy to make them conceive. So there is a sudden dip for a female reproductive system. This is about the ovarian status, egg status. There are also other factors which will make them infertile. It could be ovulation disorder, fallopian tube problem. If the age is more than 37, of course, low coital frequency as we discussed earlier, smoking, underweight, obesity, and then the diseases comes. The last comes the diseases. What are the diseases we have? What we have understood as endometriosis, pelvic inflammatory diseases, fibroid. These are all the pathology. Pathology, we have to correct it to make them conceive. But that comes a very minimal group. All other parts only makes a majority to problems for them, which is making them difficult to conceive. This is about the female conception. So postponing the first conception attempt from 25 to 30 years. Just see the number. Just postponing the first conception attempt from 25 to 30 years reduces the mean number of children from 2 to 1.7, and the infertility procedures goes up from 9.8 to 15.8%, almost close to 1.5 times. So just 5 years, if you're going to postpone your fertility thing, your infertility procedures and treatment, you will require almost 1.5 times more to make yourself conceive. That's a huge number. So the right age is between 21 to 28. And when you touch 30, it drastically falls. So always plan your pregnancy earlier and then go for all your financial, emotional and other settlements. Now this one we have to understand. This is a topic called social freezing. It has become very, very popular now. So in every other media also we are trying to concentrate on elaborating this about social freezing. What is social freezing is egg freezing. That is, if a girl wants to get married late, if a girl wants to have a child late, after 35, after settling completely, whatever the settlement they think, it can be emotional, physical, or it could be a financial, whatever it is, or it can be a professional, whatever settlement, and they think 35 they want to conceive, there is an option of giving them injections, taking their oocytes out, and then freezing their egg and keeping it. So about 22 or 23, we freeze an egg of 20 to 22-year-old girl, and then when they are ready, it can be kept for 10 years or 15 years, and when they are ready for their conception, maybe around after 30, they will have young oocytes. So we can take those oocytes out and mix it with the husband's sperm and then create an embryo, and then we can make her conceive. The why we are opening up on the social freezing and egg freezing is lot of donor programs are coming into India. Because after 35, they don't have a proper egg in hand, so they go for a donor oocyte program. So we get donor oocytes from another girl, her gene, and then transfer with the husband's sperm to her uterus. Then comes a stress. Isolated stress alone will not cause fertility issues, but still we counsel them, your stress factor has to go down, because to calm them, to make them more compliant for treatment, we always tell that. But stress is not the isolated thing that will cause it a fertility issue. And then coitus in the fixed fertile period, that's what we see very, very common now because of this social media and this Googling thing. They see Google and it says 14th day is your ovulation day, and many couples, they restrict only to one day. That's only 14th day. They'll try on the 14th day, they'll stop. And they'll say in the Google said 14, the calendar said 14. They will have a lot of calendar and apps, every apps they will have. They'll say 12th day I tried, 14th day I tried, then I stop. It doesn't work that way. Never it will work. Pregnancy will never work that way. It will be around like 2 to 3 times per week, unless otherwise you try that way, you're not going to get a conception. And then comes the post-coital perineal washing, which is very, very common question that we hear nowadays. Post-coital perineal washing will prevent pregnancy. And earlier we weren't hearing all this stuff, but last 4-5 years we are hearing all that. I don't know, maybe there is talk which is going on into the YouTube or somebody is talking about it. So they come, they keep a pillow under their bottom, they lift their legs and keep, and the girls stay the same way till morning 4-5 o'clock, which is absolutely nonsense. Okay, so post-coital perineal washing after a minute or so, you will not prevent the pregnancy. The nature has devised in such a way that sperms migrate in matter of seconds, hardly in seconds. It has such a motility, it migrates in matter of few seconds. So post-coital perineal washing will not prevent your pregnancy. Okay, and then comes the male child myth. So when they have the first child, a female child, or even for the first child, they come for a male child. So what are the things they ask us is, early morning timing of sexual intercourse will lead to a male child, Chinese calendar, and some astrologer will say some frequency in a month. In the morning, in the moon red to nala, they'll sleep off, they'll keep alarm, they'll get up, and then they will try. that will lead to a male child. This is what we hear it. This is a very common thing that we hear every other day. So when we try this way, will we achieve a male child? 100% no. And any ART technique like IUI or IVF conception, will that lead to a male child? 100% no. Okay, this X or Y chromosome, whatever the chromosome which a sperm is fusing with the female chromosome, if X is delivered from the sperm to the female X, then it comes a female. If Y joins with this X, it comes as a boy. There is no judgment, there is no treatment to make that embryo as an XY embryo. So please, whenever anybody is suggesting this, if anybody on YouTube or social media they're talking about it, please unsubscribe that channel from yours and then don't go into this male child myth. Anyway, thank you. This was a long thing that I spoke. I don't know how much you all followed this. Thank you for patient listening.
Ma'am, we actually enjoyed your talk so much. So it was actually about the ground reality in fertility, especially the myths part, ma'am. And I also thank the management for the opportunity, and it is actually glad to see that they're taking initiatives to promote a healthy living. Most of them faculties நினைக்கிறேன், பட் எங்களை மாதிரியே ஃப்ரண்ட் ரோஸ்லாம் காலி பண்ணி பின்னாடி உட்காந்துருக்கீங்களே, பரவாயில்லையா? சரி, okay. So we thought we'll have a short session on adult vaccination today. I'll start with a quote. When meditating over a disease, I never think of finding a remedy for it, but instead a means of prevention. So this is a famous quote by Louis Pasteur. இது எதுவும் இல்லைங்க, இது வருமுன் காப்போம், அதுதான். This applies not only to diseases or hospital setup. This is common in any scenario. Like for example, industry-ஆ இருக்கட்டும், இல்லை ஒரு மேனேஜ்மெண்ட் இதாக இருக்கட்டும், இன்ஃபேக்ட் இன் ஃபேமிலிஸ் ஒரு ப்ராப்ளம் வந்ததுக்கு அப்புறமா, இல்லை ஒரு ஃபினான்ஷியல் கிரைசிஸ் வந்ததுக்கு அப்புறமா என்ன பண்ணுறதுன்னு யோசிக்கிறதுக்கு பதிலாக வராமல் இருக்கிறதுக்கு நம்ம என்ன பண்ண முடியும் அப்படிங்கிறத பார்க்குறது வந்து மோர் இம்பார்ட்டண்ட். ஸோ தட் இஸ் வாட் வில் பி டிஸ்கஸிங் அபவுட் டுடே. So in fact, in public health strategy, if we see what are the ways to prevent a major untoward event from happening, அது ஒரு பப்ளிக் ஹெல்த்ல ஒரு பெரிய இம்பாக்ட் ஆகாம பார்க்கறதுக்கு ரெண்டு மேஜர் ஸ்ட்ராட்டஜிஸ் இருக்கு. ஒன்று, of course, it will be the topic of discussion today, the vaccination. There is one another strategy. Any guesses from audience? இது இன்ட்ராக்டிவ் செஷன் ஆரம்பத்திலே சொல்லிட்டேன். ஸோ ஒரு பப்ளிக் ஹெல்த்தில் ஒரு மேஜராக ஒரு டிசீஸ் வந்து அவுட் பிரேக் ஆகாமல் பார்த்துக்கிறதுக்கு என்ன ஒரு ஸ்டெப் வந்து கவர்மெண்ட் எடுத்தால் எஃபெக்டாக இருக்கும்னு நினைக்கிறீங்க? கிரேட். ஸோ ஐ திங்க் அதனால தான் எஸ்ஆர்ஹெச் அகாடமிக்ஸ். அடுத்தது, நீங்கள் கோவிட் மறந்துட்டீங்களா? ஃபோன் பண்ணாலே வருமே, காய்ச்சல், இருமல், சளி, உடம்பு வலி ஏதாவது இருந்தால் மருத்துவரை அணுகவும். அடுத்த லைனு வேக்சின்ஸ். ஓகே. சோஷியல் டிஸ்டன்சிங். ஸோ கை கழுவுறது, 10 அடி தள்ளி நிற்கிறது. ஸோ ஆக்சுவலி இட் இஸ் சானிடேஷன். இட் சவுண்ட் சிம்பிள், பட் சானிடேஷன் அண்ட் வேக்சினேஷன் இது ரெண்டுமே தே ஆர் ப்ரூவன் ஸ்ட்ராட்டஜிஸ் டு ப்ரிவெண்ட் அ பப்ளிக் ஹெல்த் மேஜர் டிசாஸ்டர் ஆக்சுவலாக. ஸோ அதில் ஒன்றான வேக்சினேஷன் பற்றி தான் இன்றைக்கி நம்ம பார்க்க போகிறோம். So before we talk about adult vaccine, what are vaccines? These are actually biological preparations which are intended to produce immunity to a disease by stimulating the production of antibodies. அதாவது அந்த கிருமியில் இருக்கக்கூடிய ஏதாவது ஒரு பார்ட், இட் கேன் பி ஆஸ் சச் அந்த மைக்ரோ ஆர்கானிசமே நம்ம பாடிக்குள்ளே இன்ட்ரடியூஸ் பண்ணலாம். அதாவது பாம்பு பிடுங்கின இது மாதிரி, பல்லு பிடுங்கின பாம்பு மாதிரி. ஸோ அதில் இருக்கக்கூடிய அந்த விஷத்தன்மை, அதாவது பெத்தோஜெனிசிட்டியை நம்ம ரிமூவ் பண்ணிட்டு அந்த பர்டிகுலர் மைக்ரோ ஆர்கானிசம்ல இருக்கக்கூடிய ஏதாவது ஒரு மெசேஜை நம்ம பாடிக்கு கொடுக்கும்போது நம்மளோட பாடியோட இம்யூன் சிஸ்டம் will actually identify it, remember it, and next time when the actual pathogen infects us, it will fight better. So அதுதான் கான்செப்ட் ஆஃப் வேக்சின்ஸ். Most important thing is it will not cause the disease in the person, but it will prompt their immune system to respond much better than like how it was if it was the pathogen which was entering. So whatever enters our body, it is called the antigen. அதுக்கு நம்ம பாடி ஒரு இம்யூன் சிஸ்டம் கொடுக்கக்கூடிய ரெஸ்பான்ஸ் பேர் ஆன்டிபாடி. ஸோ நெக்ஸ்ட் டைம் அதே மாதிரி ஒரு ஆர்கானிசம் நம்ம பாடிக்குள்ளே என்டர் ஆகும்போது நம்மளோட இம்யூன் சிஸ்டம் அதை ஞாபகம் வச்சுக்கிட்டு இட் வில் ஃபைட் ஈவன் ஃபாஸ்டர் அண்ட் மோர் எஃபெக்டிவ். அதாவது ஒரு வாட்டி நம்ம வாழ்க்கையில் அடிபட்டால் நெக்ஸ்ட் டைம் வந்து எப்படி நம்ம ரொம்ப அவேராக இருப்போமோ அதே மெசேஜை தான் வந்து we are trying to give through vaccines. ஸோ சில்ட்ரனுக்கு கண்டிப்பாக வேக்சினேஷன் பற்றி எல்லாத்துக்குமே ஒரு அவேர்னஸ் இருக்கும். அடல்ட்டுக்கு வேக்சின்ஸ் கொடுக்கணுமா? உங்களோட ஐடியா என்ன? ஏன் கொடுக்கணும்? இன்கேஸ் கொடுக்கணும்னு நீங்கள் ஃபீல் பண்ணீங்கன்னா அடல்ட்ஸுக்கு வேக்சினேஷன் தேவையா? ஓகே. எதனால அடல்ட்டுக்கு வேக்சின்ஸ் கொடுக்கணும்? Good. So கோவிட்ல வந்து it was மெயினாக நம்ம கொடுத்த பர்பஸ் டு பிரேக் த டிரான்ஸ்மிஷன் பிகாஸ் இட் வாஸ் ஸோ ரேம்பண்ட். ஸோ அந்த செயினை பிரேக் பண்ணுறதுக்கு we needed an immune population. ஸோ அதுக்காக we had to vaccinate during COVID time. வேற இம்யூனிட்டின்னு சொன்னீங்க, கரெக்ட். ஸோ ஆஸ் ஏஜ் அட்வான்சஸ், இப்போ நமக்கு எப்படின்னா சின்ன வயசுல நான் 2வது படிக்கும்போது எனக்கு அம்மா வந்திருக்குன்னு சொல்லியிருக்காங்க, ஆனால் எனக்கு தெரியாது. ஸோ நமக்கே மறக்கக்கூடிய ஒரு விஷயம், நம்ம பாடியில் எக்ஸ்போஸ் ஆகி இம்யூன் சிஸ்டம் வந்து அதுக்கு டியூன் ஆயிருந்தா கூட பிகாஸ் ஃபர்தர் எக்ஸ்போஷர்ஸ் இல்லாததுனால இம்யூன் சிஸ்டம் will also forget what exposure it had. So previous, even if we have got the infection or even if we are immunized against particular disease, there is always a chance that the memory will actually wane. ஸோ அந்த மெமரியை நம்ம பூஸ்ட் பண்ணால் மட்டும்தான் அந்த ப்ரொடெக்ஷன் வில் ஆக்சுவலி லாஸ்ட் லாங். ஸோ அந்த ஒரு பர்பஸ்க்காகவும் நம்ம அடல்ட்ஸ்க்கு வேக்சினேட் பண்ணணும். அண்ட் ஆல்சோ ஆஸ் ஏஜ் அட்வான்சஸ் வி பிகம் மோர் சசெப்டபிள் பிகாஸ் ஃபங்க்ஷனாலிட்டி ஆஃப் த இம்யூன் சிஸ்டம் ஆல்சோ கம்ஸ் டவுன் வித் ஏஜ். ஸோ வயசு ஆக ஆக அந்த இம்யூன் சிஸ்டம்க்கு இருக்கக்கூடிய ஒரு மிஷினரி மாதிரி தான் 10 வருஷம் இனிஷியலாக வாங்கும்போது இருக்கக்கூடிய எஃபிகசி வந்து ஆஃப்டர் 10 years or 12 years இருக்காது. ஸோ நம்ம அதுக்கு மெயின்டெனன்ஸ் பண்ணுற மாதிரி தான் அதே தான் வேக்சினேஷன். அண்ட் ஆல்சோ டயபெட்டிஸ், இப்போ வந்து நமக்கு மேம் சொன்ன மாதிரி இது வந்து கேபிட்டல் ஆஃப் இந்தியா, லைக் டயபெட்டிஸ் இஸ் நவ் தி மோஸ்ட் காமன். இது இப்போ வீட்டில் இது இருக்கா அது இருக்காங்கிறத விட இவங்களுக்கு சுகர் இருக்கா ப்ரெஷர் இருக்கா அப்படி தான் நம்ம வந்து எல்லாருமே யோசிக்க வேண்டியதாக இருக்குது. ஸோ ஃபார் ஈச் கோமார்பிட் தட் வி டெவலப் தி ஃபங்க்ஷனாலிட்டி ஆஃப் த இம்யூன் சிஸ்டம் அகெயின் கம்ஸ் டவுன். ஸோ அதனால அதுவும் ஒரு கான்செப்ட். வெறும் டிசீஸ் ஆஸ்பெக்ட், டிசீஸ் ப்ரிவென்ஷன் இந்த மாதிரி நெகட்டிவ் ஆஸ்பெக்டில் மட்டுமே பார்க்காம ஒரு பாசிட்டிவ் ஆஸ்பெக்ட்டுக்கு நம்ம வேக்சினேஷன் பற்றி பேசணும் அப்படின்னா ஃபார் ட்ராவல் பர்பஸ் now it has become a trend. எல்லாருமே ஒரு பிரேக் எடுக்கிறோம், நியூ பிளேசஸ் வந்து போய் எக்ஸ்ப்ளோர் பண்ணணும்னு நினைக்கிறோம். ஸோ ஃபார் ட்ராவல் ஆல்சோ we have a separate vaccine recommendation. One another concept is called as herd immunity. இந்த வேக்சின் ப்ரிவென்டபிள் டிசீஸில் சமுதாய நலனுக்காக நம்ம எடுக்கக்கூடிய வேக்சின் பேர் வந்து ஹர்ட் இம்யூனிட்டி. அதாவது சிம்பிளாக சொல்லணும்னா இப்போ ஒரு 100 பேர் இருக்கக்கூடிய ஒரு சின்ன பிளேஸ், ஒரு கம்யூனிட்டியில் ஆல்மோஸ்ட் 80% ஆஃப் த பீப்புள் இஃப் தே ஆர் வேக்சினேட்டட், எப்படி நம்ம மெமரிக்கு வந்து இது முன்னாடி எனக்கு இந்த வேக்சின் நம்ம எடுத்திருந்தோங்கிறது போயிடுதோ அதே மாதிரி இஃப் த மைக்ரோ ஆர்கானிசம் comes in contact with almost 80 people who are already vaccinated, who are already immune, அந்த ஆர்கானிசம்க்கு உற்சாகம் போயிடும். நான் போய் பார்க்குறவங்க எல்லாம் இம்யூனாக இருக்காங்க, இதுக்கு மேலே நான் வேலை செஞ்சு என்ன பண்ண போகிறேன் அப்படின்னு சொல்லி 80 பேர் தான் வேக்சின் எடுத்திருந்தாலும் the remaining 20 people who have not taken their vaccine will not get infected because the pathogen loses its vigor. ஸோ அந்த கான்செப்ட் பேர் தான் ஹர்ட் இம்யூனிட்டி. இந்த ஹர்ட் இம்யூனிட்டி எதில் ரொம்ப ரொம்ப நமக்கு இம்பார்ட்டன்ட் அப்படின்னா அதுக்காக தான் நம்ம ஆக்சுவலாக மேஜராக கோவிட் டைமில் எல்லாரையும் வேக்சினேட் பண்ண சொன்னதுக்கு ரீசன் அதுதான். இஃப் த பேத்தஜன் இஸ் கோயிங் டு ரிப்பீட்டட்லி மீட் பீப்புள் ஹூ ஹவ் டெவலப்ட் இம்யூனிட்டி அகெயின்ஸ்ட் இட் வில் ஸ்டாப் டூயிங் இட்ஸ் ஒர்க். ஸோ அதுக்காக தான் எடுக்க சொன்னாங்க. இந்த கான்செப்ட் இன்னொரு பாப்புலேஷனில் எங்கே ரொம்ப நமக்கு முக்கியம் அப்படின்னு பார்த்தோம்னா, இஃப் at home or in the community immune compromised patients who cannot take the vaccines இருந்தாங்கன்னா, like for example pregnancy timeல அவங்கள vaccines எடுக்க முடியாது, or transplant patients இல்ல cancer patients, இவங்களால ஒரு because of their immune compromised status if they are not able to take the vaccines, அவங்கள சுத்தி இருக்கிறவங்க வந்து vaccines எடுத்திருந்தாங்கன்னா அவங்க இன்ஃபெக்ஷனை வீட்டுக்கு கூட்டிட்டு வர மாட்டாங்க, அது மூலமா அந்த பர்டிகுலர் பேஷண்ட்ஸ்க்கு இன்ஃபெக்ஷன் வராது. ஸோ இந்த கான்செப்ட் பேர் ஹர்ட் இம்யூனிட்டி. ஸோ தீஸ் ஆர் தி அட்வான்டேஜஸ் ஆஃப் அடல்ட் வேக்சினேஷன் ஆர் த நீட் ஃபார் கெட்டிங் அன் அடல்ட் வேக்சினேட்டட். But we all know this concept is not actually reached in the community. What are all the bottlenecks in the adult vaccination program? So the base of the problem என்னன்னு பார்த்தோம் அப்படின்னா it is limited perception. Until we know the strength of the enemy, we won't actually take actions to prevent it. ஸோ வேக்சின் ப்ரிவென்டபிள் டிசீஸோட பேர்டன் தெரியாத வரைக்கும் நம்ம இதை பற்றி யோசிக்க மாட்டோம். கோவிட்ல நமக்கு வந்து தினம் காலையில் ஒரு நம்பர் ஈவினிங் ஒரு நம்பர்னு சொல்லி நியூ கேசஸ் வர வி ஹேட் அன் அப்டேட். ஸோ வி நியூ த நம்பர்ஸ். வேற இப்போ நமக்கு வேக்சின் ப்ரிவென்டபிள் டிசீஸ்ன்னு சொல்லக்கூடிய இன்ஃப்ளூயன்ஸாக இருக்கட்டும், நியூமோகாக்கஸாக இருக்கட்டும், இது வந்து ரேம்பண்ட்டாக இருக்குது, இது ஒரு சிக்னிஃபிகண்ட் பேர்டன் டு த சொசைட்டி கொடுக்குதுன்னு தெரியாததுனால we are not actually thinking about vaccination. In fact, US data படி 20 to 30% of the death is actually attributed to flu. ஸோ 35,000 டெத்ஸ் இயர்லி அவங்களுக்கு வந்து ஃப்ளூனால மட்டுமே. ஸோ இந்த ஸ்டாட்டிஸ்டிக்ஸ் இல்லை, இந்த பேர்டனை பற்றி நமக்கு ஒரு அவேர்னஸ் இல்லை அப்படின்னா we won't think of taking the vaccines. The next problem is doubtful minds. நல்லா இருக்கேன் நான், இதை எடுத்து ஏதாச்சும் ஆகிடுமோ, இதுக்கு போய் இவ்வளோ செலவு பண்ணணுமா அப்படின்ட்டு பேஷண்ட் சைட்லேருந்து கண்டிப்பாக இந்த தாட்ஸ் நிறைய இருக்குது. This is not only among patients but even among healthcare workers. There are a lot of perceptions and they really hesitate to suggest vaccines. Again, one cost, ஒரு வேக்சின் சொல்லும்போதே 3000 4000 சொல்கிறோன்னா ஏற்றுப்பாங்களான்னு தெரியாது. ஸோ ப்ராப்ளம் வரும்போது பார்த்துக்கலாம் அப்படிங்கிற ஆட்டிடியூட். ப்ளஸ் ஒன் மோர் திங் இஸ், if the patient comes to us with a health problem and then you give them treatment or suggestion, அதில் ஏதாவது காம்ப்ளிகேஷன் நடந்துச்சுன்னா அதை ஏற்றுக்க ரெடியாக இருப்பாங்க. பட் நல்லா இருக்கேன், இன்னும் நீங்கள் நல்லா இருக்கிறதுக்காக இந்த வேக்சின் சொல்லி நம்ம அடிஷ்னலாக ஒரு இது சொல்லும்போது, if at all something untoward happens, then the responsibility or the problem becomes more. So and the doubtful minds is of concern. Second thing is, healthy people coming into contact with healthcare worker is little difficult. So only நமக்கு அதாவது ஒரு common platform இருந்ததுன்னா மட்டும்தான் we will be able to talk to them about it. So that is also a difficulty. And one another problem is, childrenக்கு we have universal immunization programs. That is, it is standardized. In the age, இந்த cut off இருந்துச்சு அப்படின்னா இந்த vaccines தான். But for adults, unfortunately, it is not like that. It depends on the age, the comorbid status, the immune status of the patient. Because it is not universal, it is very difficult for us to follow an adult vaccination. Now that we know the advantages and disadvantages of adult vaccination, we will see what are all the vaccine preventable diseases. Almost நமக்கு இப்போ 14 டிசீசஸ் கிட்ட இருக்குது. லைக் ஃபார் எக்ஸாம்பிள் ஜாண்டிஸ் ப்ரிவென்ட் பண்ணக்கூடிய ஹெப்படைட்டிஸ் A or B, அண்ட் சிவியர் நிமோனியா ஒரு லங் இன்ஃபெக்ஷன் காஸ் பண்ணி ஐசியூ கேர் தேவைப்படக்கூடிய இன்ஃப்ளூயன்ஸா அண்ட் நியூமோகாக்கை, அண்ட் அம்மை அந்த வகையை சேர்ந்தக்கூடிய வைரல் வேக்சின்ஸ் வந்து பார்த்தோம்னா சிக்கன் பாக்ஸ், மம்ஸ், மீசல்ஸ் இதெல்லாமே வந்து அவைலபிளாக இருக்குது. So again, how do we decide which patient needs which vaccine? So it depends on ஒரு categorization வந்து depending upon the age and the comorbidity. The other ways to categorize is, as we already discussed, to boost the memory. Previous exposure இருக்கு, it is only to insist the immune system that we have forgotten and we have to be ready for this particular disease. And second thing is to control transmission. When it is going to be a new event, to break the chain, அந்த பர்பஸ்க்காக போடுறது பேர் வந்து controlling transmission. A totally different categorization is special situations, which includes, again, transplant patients இருக்கலாம், இல்லை travel vaccination, that itself is a separate entity, and high risk behavior இருக்கிற individualsக்கு நம்ம கொடுக்கக்கூடிய vaccination. So this is how we categorize the need for the adult vaccines. So vaccine recommendations, we'll categorize them as for healthy individuals நம்ம காமனாக ப்ரிஸ்கிரைப் பண்ணக்கூடிய வேக்சின்ஸ் அண்ட் ஸ்பெஷல் ரெக்கமெண்டேஷன்ஸ். For healthy adults எடுத்துக்கிட்டோம் அப்படின்னா, there is DPT, which is actually diphtheria, pertussis and tetanus, measles, mumps and rubella. Of course, இது எல்லாமே இப்போதைக்கு because of good childhood vaccination programs, the incidence of all these diseases have come down. But maybe because of post-COVID effect, COVID timeல அந்த vaccination gapனால we do see now patients who are reporting to us commonly with mumps, measles, idellame we are seeing the resurgence of these disease. So it is important for us to make sure that we have adequate antibodies against these disease. The other include influenza and pneumococci. These two are actually known to cause severe respiratory illness. Human papilloma virus, this is actually advised predominantly for the adolescent group. Before they enter into the sexual activity, it is important for them to take this vaccine because it commonly cause பண்ணக்கூடியது something maroon நம்ம சொல்லக்கூடிய skin இதுல. அதுவே genital organsல if it is going to cause a wart, there is a chances that it can progress into malignancy. So female la வந்து cervical cancer cause பண்ணக்கூடிய virus தான் human papilloma virus. So this vaccine is available both for men and women. So this is one another vaccine. And zoster vaccine, அதாவது நம்ம அக்கின்னு சொல்லுவோம். ஒரு இடத்துல மட்டும் chicken pox வந்து generalized வருது, அக்கி வந்து ஒரு இடத்துல மட்டும். ஏன்னா once after chicken pox வந்து போனதுக்கு அப்புறமா this virus will hide in the nerve sheath. When our immune system gets weakened, it will get reactivated and it will affect that one particular area. So that is called as herpes zoster. So we have vaccines against that as well. Special recommendations includes hepatitis A and B, most commonly prescribed for people who are already known to have existing liver disease, and also for travelers. And one another group is healthcare workers because they come in frequent contact with patients. So hepatitis B is mandatory for those who are involved in healthcare. And meningococcal vaccine, again, Hutch pilgrimages are இருக்கட்டும். இப்போ வந்து இந்த வேக்சின் வந்து டிமாண்டில் இருக்கிறதுக்கு ரீசன் வந்து most of them are preferring to go abroad for studies. So it is now mandatory for those who are joining universities abroad. And other vaccines includes varicella and Haemophilus influenza, typhoid. I would like to pause here because இப்போ வெளியில் சாப்பிட்ற இது வந்து ரொம்ப 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 காமன் ஆயிடுச்சு. So please be aware of where you're buying the food and the standard of the preparation and all that. In fact, this week we have a 24-year-old female. She was admitted in septic shock and சொல்வது. She required ventilator, BP medicines தேவைப்பட்டுச்சு. So we didn't know what actually we are dealing with, but it turned out to be typhoid. and it all started with Pani Puri. ஸோ தயவுசெய்து கேர்ஃபுல்லாக இருங்க, சாப்பிட்ற இடத்துல எங்கே வாங்கி சாப்பிட்றீங்கிறத கொஞ்சம் பார்த்து சாப்பிடுங்க. ஸோ இஃப் யூ ஸ்டில் வுட் லைக் டு எக்ஸ்ப்ளோர் நியூ cuisines, then please take your typhoid vaccines. So next, one another killer disease is rabies. Actually, this is a 100% fatal disease. ரோடில் நடந்த ஆக்சிடென்ட்ஸ் எந்த அளவுக்கு காமனாக நடக்க ஆரம்பிக்குதோ அதே மாதிரி தான் இதுவும். திஸ் இஸ் அ வேக்சின் ப்ரிவென்டபிள் டிசீஸ். ஸோ ப்ளீஸ் மேக் ஷுர் யூ டேக் யுவர் ரேபிஸ் வேக்சின். If we are in constant contact with pets and all that, it is better to take a pre-exposure. So we have a pre-exposure vaccination as well. And cholera, Japanese encephalitis, these vaccines are usually recommended only for those who are going to endemic areas. So this is the vaccine schedule. Schedule pati I am not going to elaborate. So we just need to know the severity of the disease so that we actually take a step forward and get ourselves vaccinated. So small outline about each of the disease. So for influenza vaccine, most of us know like influenza is going to cause only maybe some cough, cold, fever, body pain. For 5 days rest, we'll resume back to work. Yes, for 75% of the people, it is so. But for remaining 25%, especially those who are diabetic, already having existing lung disease or liver disease, it can be catastrophic. It is known to cause complications like meningitis, encephalitis, cardiac failure, or severe respiratory disease requiring ICU care. Pregnancy, it can really be catastrophic because maternal complications and fetal complications are very high. So it is better to get the influenza vaccine. A small note that we need to know about influenza vaccine is this virus actually keeps mutating every year. So every year the strain changes. ஸோ ஒரு வாட்டி நான் இப்போ போட்டுட்ட வேக்சின் அதுக்கப்புறம் பார்த்துக்கலாம் அப்படி கிடையாது. இது வருஷம் ஸ்ட்ரெயின் மாறும். ஸோ இயர்லி வீல் ஹேவ் டு டேக் திஸ் வேக்சின். அண்ட் த பீக் சீசன் இஸ் யூஸ்வலி அரௌண்ட் அக்டோபர் டு மார்ச். ஸோ ஜஸ்ட் அந்த மழை ஆரம்பிக்கிறதுக்கு முன்னாடி. ஸோ அரௌண்ட் ஆகஸ்ட் செப்டம்பர் இந்த நியூ ஸ்ட்ரெயினுக்கு உண்டான வேக்சின் ரிலீஸ் பண்ணுவாங்க. ஸோ இட் இஸ் பெட்டர் வி டேக் த வேக்சின். And this point, the vaccine becomes effective against the virus 2 weeks after administration. It is not only for this vaccine, for any vaccine, for the message to enter the body, the immune system to start acting and actually to be ready to fight, it will take at least 2 weeks time period. So if we take the vaccine today, we are never protected the next day. So this is something that we should know about vaccines. The next is pneumococcal vaccine. Actually, influenza and pneumococci, they can be considered as twins. Because ஒரு வாட்டி இன்ஃப்ளூயன்ஸா நமக்கு வந்து போச்சு, ஒரு வைரல் இல்னஸ் வந்துச்சு அப்படின்னா it will actually damage the respiratory epithelium or the respiratory lining, and that will pave way for the next bacteria to come and sit and do its work. So immediately after influenza, it is always common, and we have seen patients who really come in sick requiring ICU care. So invasive pneumococcal disease, this particular bacteria not only causes pneumonia, it can also cause meningitis. And my chief always used to say, ஒரு பெஸ்ட் இன்வெஸ்ட்மெண்ட் பிளான் சொல்லுங்க அப்படின்னு கேட்டால் இட் இஸ் ஒன்லி த ஃப்ளூ அண்ட் நியூமோகாக்கல் வேக்சின். பிகாஸ் இன் அப்ராட் அகெயின் தே ஹேவ் டன் ஸ்டடீஸ் அண்ட் இட் ஹஸ் ஷோன் தட் வேக்சினில் அவங்க இன்வெஸ்ட் பண்ண மணி இட் இஸ் மச் மோர் தேன் தே ஹேட் டு ஸ்பெண்ட் ஃபார் எனி பேஷண்ட் ஹூ ஹேட் நிமோனியா ரிக்வயர்ட் ஐசியூ கேர். ஸோ அதனால் அவங்களோட இன்சூரன்ஸ் பிளானில் பிகாஸ் தேர் கவர்மெண்ட் பேஸ் ஃபார் த பேஷண்ட். ஸோ அவங்க வேக்சினில் ஸ்பெண்ட் பண்ணது மூலமாக தே சேவ் ரியலி லேக்ஸ் அண்ட் லேக்ஸ் ஆஃப் மணி because they didn't have to spend it for the patient requiring ICU care. So please think about it and take these vaccines. And next is about tetanus. This we all commonly know that after minor trauma, we are more prone. So it is better to take because every 10 years, if last 3 doses eduthirundha, it is better to take a booster every 10 years. It is more important in pregnant women because in those days it was actually the healthcare workers who used to conduct the delivery. So at the time umbilical cord cut பண்ணும்போது அந்த proper sterile techniques follow பண்ணலன்னா the neonates could get neonatal tetanus. So that is why this vaccine is important. And next, as we already mentioned, it's about herpes zoster. So the most painful part in this, after herpes, you can develop something which is called as post-herpetic neuralgia. It is a severe pain that you will actually perceive once these lesions settle. So to prevent that, this vaccine has been rolled in. Actually, earlier it was above 60 years of age. Right now we have a vaccine which is recommended for those who are above 50 years of age. And at times, though it is rare, this particular virus can cause meningitis and encephalitis, and it can also cause visual problems. Ophthalmic involvement is also common, especially if the lesions occurs around the eyes. So this is one another vaccine. And as we already mentioned, travel vaccination per se itself is a separate entity. We all knew that COVID vaccine was mandatory when we had to travel. The other vaccine actually depends on where we are planning our travel. So there's something called Yellow Book. It is freely accessible in the internet. So you'll have to just check to which area you're traveling and what is the disease which is prevalent there and what is the vaccination that they have recommended. So this is something that is recommended for Hajj pilgrims. Meningococcal is mandatory, and this yellow fever. Actually, in the yellow fever vaccine, it is not available everywhere. So if you're planning, you need to carry an yellow card actually with you. So make sure that if that center is authorized to give the yellow fever vaccine, and then take it. Just receiving the vaccine without the yellow card, it won't serve the purpose. So make sure about that also. So in short, these are the specific vaccines which are recommended for different patient group. In this, we can actually see that flu and pneumococcal vaccine is almost present in all categories. So these two vaccines, along with the tetanus vaccine, are something that we'll have to really think about. So with that, I close the session. Hope you are educated, motivated. The last tick will be for you all to get vaccinated. Thank you.